Moving forward to the next coccidia, we will be discussing the first of the intestinal coccidian parasites. So that is Cryptosporidium parvum. C. parvum is an intestinal coccidian that affects various animals like rats, guinea pigs, horses, and obviously humans. And although this is intestinal, it can spread to nearby organs like stomach, appendix, colon, rectum, and even the pulmonary tree. In immunocompetent hosts, the presentation is usually asymptomatic, walay symptoms, or if there is self-limiting acute diarrhea. When self-limiting, it may resolve without the need for intervention or administration of chemotherapeutic agent. But it's another story if immunocompromised na ang host because it can cause chronic persistent life-threatening diarrhea that are usually intractable, meaning it's hard to control, especially for AIDS patient and immunocompromised hosts. It was first described in laboratory mice by Teizier in 1907, specifically from the gastric crypts of the mice, and the first human case was documented in 1976. The intracellular form of C. parvum class is unique because it is confined in the intracellular extracytoplasmic location, meaning that it is found just below the cell membrane of the host cell of the brush border epithelium of the small intestine. Below siya sa cell membrane, pero wala siya sulod sa cytoplasm. Muna'y pasabot ang intracellular extracytoplasmic location. C. parvum is considered as the most common Cryptosporidium species infecting man. The other less common is Cryptosporidium hominis. In terms of its morphology, its oocyst is considered as the infective and the diagnostic form. And this oocyst is already sporulated in feces, meaning mature na siya na pa lang sa feces. Its morphology is that it's small, it's round, about 46 micrometers. In fact, it's the smallest oocyst among intestinal coccidians, comparing that to C. cayetanensis and C. belli. Its oocyst forms four sporozoites without sporocyst, meaning directly na siya sporozoites, and it has two types of oocysts depending on zygote development. Much of the zygote will develop into thick-walled oocysts and the rest will thin-walled oocysts. About 80% kay thick-walled. Mayong kag thick-walled, it has two-layered cyst wall and membrane. It has an outer coarse layer and an inner fine layer, and it has a suture point at one pole in which the sporozoites exist. For the thin-walled, about 20% of the zygote will be thin-walled. It has a single layered membrane, and the cyst wall is already destroyed in the intestine or contaminated fingers once it is liberated. And this is the main reason for autoinfection of the parasite, kaning thin-walled oocyst. The oocyst is also uniformly acid-fast, so remember acid-fast staining, but does not stain with iodine. So they are highly resistant and viable for long periods because of their ability to form cyst wall, and they survive chlorination, disinfectants, and even temperature up to 60 degrees Celsius. Manay characteristics sa oocyst ni C. parvum. Moving forward to their life cycle, sexual and asexual stage occur in single host, meaning it's monocynous. Kung yung kag monocynous class, it only requires one host, although that the life cycle there kay complex gyud kay sa isa ka host na nadira ang sexual and asexual stages. Again, sporulated in feces ang iyang oocyst. And if you're going to compare that with T. gondii, ang T. gondii unsporulated na siya sa feces. Its thick-walled oocyst is infectious to other persons. Mo na siya ang nagpa-spread sa infection, whereas the thin-walled oocyst is the main reason for autoinfection. And this also contributes to the chronicity of the diarrhea caused by C. parvum. This thin-walled oocyst can be transmitted by contaminated fingers. Kay dali lang mabuak ang iyahang cyst wall. So let's answer this checkpoint number 6. What is the main contributing factor of the chronicity of diarrhea caused by C. parvum in immunocompromised hosts? Is it A, living condition, B, poor diet, C, autoinfection, D, tradition? What will be our answer? The correct answer is autoinfection. Autoinfection caused by thin-walled oocysts. So here's the mode of transmission for C. parvum. That's ingestion of contaminated food or water by thick-walled oocysts, and autoinfection naman by thin-walled oocysts. The reservoir host of the parasite can be man, cattle, cat, and dogs, and other animals. For other modes of transmission, it can also be transmitted by direct contact with infected animals and even human-to-human transmission, although these two transmissions are rare. So, mo na siyang overall picture of the life cycle of the parasite, and we will be starting the life cycle in its asexual phase. So, the steps are ingestion of thick-walled oocysts and autoinfection with thin-walled oocysts, which leads to invasion, and finally, cycles of schizogony. So let's go back to the ingestion of thick-walled oocysts. So katong thick-walled oocysts, kay sila ginay mo infect sa other persons, whereas ang mo cause of autoinfections again are thin-walled oocysts. So after that one, after ingestion, kay it will travel the alimentary canal until it reaches the small intestine, and there excistation occurs. Kung may excistation, mo gawas ang sporozoites from the cyst, no, from the oocyst. So 4 sporozoites exit the cyst through the dissolution of the suture point of one of the area in its pole, and that will be aided by the pancreatic enzymes in the small intestine, particularly the trypsin and pepsin, as well as the bile salts. So after the sporozoites are liberated, that's the time that they will invade the cell through their apical complex. They will lie inside the parasitophorus vacuole, and this is what we called as the intracellular extracytoplasmic location. Take note of that, ha, kay that is unique to your C. parvum. So, to visualize it to the actual specimen, mo ni siya ang intracellular extracytoplasmic location. Naara gyud siya gawa sa cell membrane, but wala siya nasulod sa naara gyud siya sulod sa cell membrane, but wala siya sa sulod sa cytoplasmic location. So here, this can lead to the microvilli, kani sila here, na they will get blunted. So it means nga it disrupts the absorption of essential nutrients. This will be lost, leading to hypermotility and diarrhea. So na malabsorption and excessive fluid loss because of vellus changes and the overall change in the environment of the GI tract, particularly the small intestine. So after that one, after they successfully invade the brush border epithelium, they will now be able to transform into trophozoites, which will lead to the formation of type 1 murons through schizogony. So this type 1 murons will follow a cycle of schizogony. Then after that one, a few of the type 1 murons will become type 2 murons. Ang type 1 murons is capable of producing 8 merozoites, whereas the type 2 murons is capable of producing 4 merozoites. And that's the end of the asexual phase of the parasite. Now let's move forward to the sexual phase, starting with gametogony, then fertilization, and the production of thick and thin-walled oocysts. For gametogony, the type 2 murons, the merozoites of the type 2 murons may now differentiate into a microgamete and a macrogamete from gametogamy. So one microgamete can lead to 16 microgametes, and one macrogamete can only produce one macrogamete. After that one, they will follow fertilization step to form a zygote, and this zygote will secrete a cyst wall to cover it, thereby producing the thick and thin-walled oocysts. So 80% of the zygote will form the thick-walled unsporulated oocyst, and 20% will form the thin-walled and sporulated oocysts. After some time, they become sporulated within the GI tract, and they will be released in feces as sporulated oocysts already. So they do not need any sporulation in the outside environment or in the soil. The pre-patent period, the period to which the ingestion of oocysts, and after that the release of the oocysts in the feces, may last for about 4 to 22 days. Muna siya ang life cycle sa C. parvum. Again, what's unique about this? Balikon lang nato magamay. Sa asexual stage, ang atong very unique ani, kay asa sila makita dito sa brush border epithelium. Naa sila sa intracellular extracytoplasmic location, meaning just below the cell membrane pero dili part sa cytoplasm. Aside from that, another unique feature is its thick and thin-walled oocysts na sporulated na sila once it is released in feces. So, yung kalimutan na nila ha. They do not need any sporulation steps in the outside environment. Okay, let's check your knowledge by answering this checkpoint number 7. In what ways does Cryptosporidium parvum differ from Toxoplasma gondii? Is it through the number of hosts, type of sexual reproduction, quality of oocysts, or intracellular location in gut cells? So what will be our answer for this one? The correct answer is letter D. Why D? In the number of hosts, si T. gondii, it requires 2 hosts. So heterogeneous ang life cycle na siya intermediate and definitive host. For C. parvum naman, it only requires 1 host, so monogenous. As for the type of sexual reproduction, both follows gametogony or sporogony. So dili na siya mao ang answer. Correct ang 1. So sila na 1. How about the quality of oocysts? For the oocysts, if sporulated na gani, ang T. gondii na siya ay 2 sporocysts and each containing 4 sporozoids. How about for C. parvum? Ang C. parvum, ang isa ka oocyst na siya dayoy 4 sporozoids. Wala siya sporocysts. So maniglahi sila here. That's another answer. Mapilian na lang nato is the C and the D. How about for number 4, intracellular location in gut cells? For T. gondii na siya sa cytoplasm. How about for C. parvum? Extracytoplasmic, wala sa cytoplasm. So this can also be utilized in differentiating T. gondii and Cryptosporidium parvum. So the correct answer is 1, 3, and 4. So therefore, letter D. So we have here cryptosporidiosis in immunocompetent hosts. When we say cryptosporidiosis, that is the disease caused by C. parvum. Again, for immunocompetent hosts, it is usually asymptomatic, and if ever man gani, it's just a self-limiting, watery, non-bloody diarrhea. Other features: abdominal pain, nausea, anorexia, fever, and weight loss. It may cause traveler's diarrhea, which is also true for parasites like Giardia, Entamoeba histolytica, and Cyclospora cayetanensis. The incubation period, meaning the infection to the first appearance of symptoms, may last for 1 week for C. parvum. So what are the factors that contribute to the disease? So a good example of the factor is a slow infective dose, meaning na gamay ra ang kailangan para makastart og infection. Just about 10 to 100 oocysts is needed to initiate the infection of C. parvum. Aside from that, it has a large multiplication capacity. So, grabe managhan ang C. parvum oocyst inside the body of the host. And again, the small size of the oocyst will also matter, especially in the capacity of the body to house multiple oocysts inside the small intestine. The C. parvum also affects large animal and human reservoir, meaning na daghang yun silang sources para makontinue ang parasitic infection. Aside from that, zoonotic contact is one way of having the parasite C. parvum. Let's look into cryptosporidiosis in immunocompromised hosts. So this can lead to chronic, persistent, and profuse diarrhea, which like about 1 to 25 liters of stool per day. And this is accompanied with fluid and electrolyte loss that may resemble cholera and other forms of diarrhea. This can even lead to severe weight loss, wasting, and abdominal pain. And the chronicity of the symptoms is attributed to autoinfection that is caused by thin-walled oocysts. It may spread to other organs like pharynx, stomach, large intestine, and respiratory tract, and this can even involve the biliary tract, in which the patient may experience papillary stenosis, sclerosing cholangitis, and cholecystitis. In this manner, it will manifest as epigastric or right upper quadrant pain. So, ang ibawaan lang nato basta immunocompromised kay chronic and persistent yun ang iyang diarrhea. By the way, this type of diarrhea is also targeting kaning mga infants and children. Common kaayo ang outbreaks of diarrhea or C. parvum in infants and in children. Ayon ano yung kalimti. For the laboratory diagnosis, so we can collect stool samples in 3 consecutive manner. That is to demonstrate the spherical oocyst of the parasite and with the size of 4 to 6 micrometers. In DFS class or direct fecal smear, it's very difficult to visualize the oocysts because they are colorless. That's why we need to perform acid-fast staining. When you say acid-fast staining, again, it is a type of staining that is primarily used for a bacteria that is the causative agent of Mycobacterium tuberculosis. It stains a component in the cell wall of this bacteria, that is the mycolic acid. So we will be modifying this acid-fast staining in order to detect a component in the cyst wall of the intestinal coccidian oocysts. For acid-fast staining, what you usually perform is the modified Ziehl-Neelsen staining. That's the method of choice. Kaning Ziehl-Neelsen class, it's also called as the hot method. There's a cold method for that, and that is what we call as the Kenyon method. In acid-fast staining, na siya 4 primary components. We have the primary stain, the mordant, the decolorizing agent, and the secondary or counter stain. For the primary stain, that is carbolfoxin. The mordant for Ziehl-Neelsen is heat. Decolorizing agent is in the form of acid alcohol. By the way, this is the one that is being modified. For secondary or counter stain, that is methylene blue. Kung mangutana mo what is a mordant class, a mordant is the one that stabilizes the complexes of the primary stain with that of the cell wall component that is stained by the acid-fast staining. So, in, say for example, na stain na sa primary stain na carbolfoxin, if that is an acid-fast positive, iyang i-retain na ang primary stain. So, dili na mawala ang primary stain, and in counter stain, dili na siya ma-stain sa counter stain. But, if that is acid-fast negative class, kay dili niya ma-retain ang primary stain, ang iyang ma-retain na noon is the secondary stain or the counter stain. So, inga na lang na sila. By the way, di ba niingon man ta nga ang decolorizing step or decolorizing agent mo ay modified. Sa original na Ziehl-Neelsen class, it's 3% sulfuric acid and 95% ethyl alcohol. Pero sa modified Ziehl-Neelsen, it's 1% sulfuric acid and 70% alcohol. So, inga na ang modification nga nahitabo. By the way, if you will be asked in what is the most important step in acid-fast staining, that would be decolorization step with acid alcohol. Kaya anha man nato ma-differentiate si acid-fast positive with acid-fast negative microorganisms. So how does C. parvum appears in modified Ziehl-Neelsen? C. parvum appears as uniformly acid-fast na mga na mga oocysts. So they are red, oval, or spherical oocysts against background. Again, red na siya. Kaya ang color manggod sa carbolfoxin is red, whereas ang color sa methylene blue, of course, it's blue. Other types of staining that we can use include rapid stapranine methylene blue method and carbolfoxin negative staining. The limitations for acid-fast staining class is that it has a low sensitivity and we need to have a minimum concentration of oocysts. So it's greater than 50,000 oocysts per ml of stool in order to have a good acid-fast result. Other types of staining that we can perform is this fluorescent staining. So again, that's with the use of a fluorophore or fluorochrome, but the limitation for this is photo bleaching. When we say photo bleaching, that is with the loss of fluorescence over time. It's very sensitive manggod ng fluorescent staining. We can perform auramine phenol that stains the lipid components of the oocysts, and the oocysts will appear bright yellow. For acridine orange naman, it stains the nucleic acid. DNA will appear yellow-green. RNA appears bright red or orange. C. parvum class is not autofluorescent under UV epifluorescent microscopy, unlike other types of coccidian parasites, especially C. cayetanensis and C. belli. Immunofluorescent staining can also be utilized. That is, we can utilize a fluorescent labeled monoclonal antibody against the cyst wall antigen of Cryptosporidium parvum. Immunofluorescent staining is considered as more sensitive and specific than acid-fast staining. Direct fluorescent antibody staining is in fact considered as the gold standard for the diagnosis of C. parvum, whereas indirect immunofluorescent is the definitive identification step for C. parvum. We can also perform concentration techniques for concentrating low parasitemia or low oocyst load. That is primarily with the use of Schetter sugar flotation technique. Kung kaning Schetter sugar class, that is composed of boiled sugar with phenol, and it's widely used for coccidia. The SG of the not of the parasite, but the SG of the solution is about 1.27. That's why the oocyst of the parasite floats, because of the high density solution. Other forms of concentration technique that we can employ include zinc sulfate flotation and saturated salt flotation, and the sedimentation technique FECT. We can also perform serodiagnosis like antibody detection. We can detect anti-oocyst antibody. We can detect IgM and IgG in patient serum, and these are possible within 2 months of the acute infection. Antibody detection can be performed through ELISA or immunofluorescence. Antigen detection naman class, we can detect for Cryptosporidium parvum coproantigen. When you say coproantigen, that means antigen from stool. This can be done through ELISA or immunochromatographic tests, which we can simultaneously detect the 3 antigens of 3 parasites like Cryptosporidium parvum, Georgia lamblia, and Entamoeba histolytica. For molecular diagnosis, we can utilize PCR to differentiate C. parvum genotypes, and we can also utilize Western blot technique, which detects specific proteins using antibodies. So the type of proteins that we can detect are the 17 KDA and 27 KDA sporozoite antigens. For histopathology, we can demonstrate the different developmental stages of the parasite from intestinal biopsy specimen. Other forms of tests that we can rely to is low CD4 T cell, which signals nga ang pasyente kay or ang host kay immunocompromised, and the fecal leukocyte marker lactoferrin, which indicates the presence of pus cells in feces. Now, in terms of treatment, no chemotherapeutic agent is actually effective against C. parvum. Um, in chemotherapy, manggod, ang mga mild cases of self-limiting, it doesn't need to have a chemotherapeutic agent administered. For fluid replacement, we can perform oral rehydration therapy, especially for diarrhea, lactose-free glutamine, and supplemented diet. In severe cases, we can perform nitazoxanide, or we can administer, or the doctor may administer nitazoxanide. Nitazoxanide class inhibits enzyme system essential for anaerobic energy metabolism. Aside from nitazoxanides, we can also, or the doctor may also administer paromomycin that inhibits protein synthesis of the bacteria. For its prevention, minimizing exposure to animal and human feces is very important. Proper hand washing and personal hygiene, and also the use of submicron filters. Next, we have checkpoint number 8. How does C. parvum oocyst appear in modified acid-fast staining? Is it letter A, red rounded bodies against purple background? Letter B, pink rounded bodies against blue background? C, blue elongated bodies against yellow background? Or letter D, yellow elongated bodies against red background? So take note that C. parvum is uniformly acid-fast in modified acid-fast staining. So it appears pink or red rounded bodies against blue background. The correct answer is letter B. The next intestinal coccidian that we will be talking about has the largest oocyst and is also the only elliptical oocyst out there, and that is Isospora belli, which is already renamed to Cystoisospora belli. So this C. belli is the only species that infect man, and there are no other animal reservoir. Bellium, or this belli, came from the word bellium, meaning war associated, because during the time of First World War, it is the type of diarrhea that occurs in troops stationed in the Middle East. This belongs to the family Sarcocystidae. It's associated with AIDS patient, and it's rare in HIV infected children. And this is what separates C. belli or I. belli with Cryptosporidium parvum, because Cryptosporidium parvum, diba, it's common in infants and children. This Isospora belli class is common in tropical and subtropical countries like South America, Africa, and Southeast Asia. Its oocyst is oval and elliptical or elongated ovoid, like this one here. Its dimension is about 23 to 26 micrometers by 12 to 17 micrometers. Its oocyst also contains 2 sporocysts, each with 4 sporozoites, much the same with T. gondii. Whereas for C. parvum again, it only contains 4 sporozoites and no sporocysts. It has a thin, smooth, 2-layered cyst wall, and this is unsporulated in feces. Unlike C. parvum nga sporulated na daan sa feces, Isospora belli unsporulated pa na siya sa feces, meaning that it needs sporulation or maturation in the soil or outside environment, in which ang sporoblast will transform into sporocysts. Ang sporulated oocysts, they are now the infective stages of the parasite. The mode of transmission is ingestion of contaminated food and water with sporulated oocysts. Again, just like your C. parvum, it utilizes one host, therefore its life cycle is monocynous. And within that one host, the sexual and asexual stages occur. For its life cycle, it starts with the asexual cycle by ingestion of sporulated oocysts, then invasion by sporozoites, transformation to trophozoite, schizogony, and release of merozoites. So ingestion of sporulated oocysts happens together with the contaminated food and water. And after that, this sporulated oocysts will liberate the sporozoites that will invade the intestinal epithelial cells. Particularly, anha na sila mo invade sa proximal small intestinal area, the duodenum and jejunum. So after the sporozoites invade, they will transform into trophozoites, which will now begin to undergo schizogony. So the trophozoites multiply, forming the schizont, and the schizont will undergo schizogony to form the merozoites. So ani ang pagkasunod-sunod niya. These merozoites are released, and this will invade adjacent cells, and the cycle will repeat until such time na daghan na kaayo ang mga merozoites. So merozoites will initiate the sexual cycle through gametogony, then fertilization, oocyst formation, and sporulation. So that means that some of the merozoites will transform into macro and microgamete, and this will now lead to the fertilization of macrogamete by microgametes. Once fertilization occurs, this will now form the zygote, which will secrete the cyst wall, and the cyst wall will form eventually into unsporulated oocysts that are elliptical in shape. Remember that that is unsporulated oocysts. That is the diagnostic stage of the parasite. Okay? So, kani unsporulated oocysts will sporulate in the outside environment to become infective sporulated oocysts. So, we have here checkpoint number 9. In the life cycle of Isospora belli, which of the following statements accurately describes the process? Is it letter A, the oocyst undergoes sexual reproduction within the definitive host, producing sporozoites that infect the human host? Or letter B, the sporozoites are released from the oocyst and invade epithelial cells in the intestine? Letter C, the sexual phase of the parasite's life cycle occurs in the intestinal epithelial cells of the victor? Or letter D, the oocyst excreted by the host is immediately infective to the next host? What will be our answer? The correct answer is letter B. So in letter A man good class, unsporulated pa within the body of the host. So that doesn't mean na directly yun siya maka-infect sa intermediate host. So it's still not yet infective. For letter C naman, the sexual phase of the parasite's life cycle occur in the intestinal epithelial cells of the victor. The parasite, because it belongs to because it belongs to Emerida, it does not utilize any victor. Wala gyud victor ang Isospora belli. In fact, one host ra ganin ang naa niya. For letter D naman, the oocyst excreted by the host is immediately infective to the next host. Wala pa. Kaya sporulated palagi ang mga oocysts, mag-need pa sila og sporulation in the outside environment. So let's look into the disease caused by Isospora belli, and that is isosporiasis or cystoisosporiasis. It is usually asymptomatic and less severe than cryptosporidiosis. Outbreak is also less common. In fact, siya ang makakause of least common outbreaks among the three. So, ang pinaka-common sa outbreak is Cryptosporidium parvum, followed by Cyclospora cayetanensis, and lastly C. Isospora belli. In acute infection, it causes fever, abdominal pain, which are non-specific symptoms, and watery, non-bloody diarrhea. In immunocompromised individuals, it is severe. So that will be in a form of chronic, profuse, watery diarrhea, and it becomes more severe if there is biliary tract involvement. For the laboratory diagnosis, it's also similar to cryptosporidiosis. In terms of staining in acid-fast stain, the oocysts are uniformly acid-fast, pink or red colored elliptical oocysts. Other types of staining method that we can perform is lactophenol cotton blue and safranin. We can also stain them with GEMSA and auramine rhodamine dye. Now, other evidences that indirectly show the presence of isosporiasis is high fecal fat content of the stool, the presence of fatty acid crystals, and Charcot-Leyden crystals. The oocyst of Isospora belli is autofluorescent in fluorescent microscopy, in UV fluorescent microscopy. Whereas for C. parvum, as mentioned before, it's not autofluorescent. Now, if we have multiple negative stool exams, what we can perform is duodenal aspirate, which is utilized in order to demonstrate oocyst. By the way, this is how the oocyst of Isospora belli appears in UV microscopy. Next, intestinal biopsy can also be performed in upper gastrointestinal endoscopy, which can demonstrate oocyst. For molecular methods, we can utilize polymerase chain reaction. Other types of tests that can be utilized can be the demonstration of peripheral blood eosinophilia, meaning an increase in eosinophils, and low CD4 T cell count. For the treatment, no treatment is indicated in self-limiting infection, but cotrimoxazole can be used as primary treatment option for severe cases. Aside from that, pyrimethamine and nitazoxanide can also be utilized. We have checkpoint number 10. A direct wet mount prepared from a diaric stool sample revealed what appeared as Isospora belli. What can be correctly inferred from this finding? So look at this one here. Monacea ang oocyst sa Isospora belli. This life stage is infective to the intermediate host. This life stage contains sporozoites. This life stage has already sporulated. This life stage has undergone gametogony. What will be our correct answer for this one? The correct answer is letter D. So this life stage is infective to the intermediate host, which is wrong because this is still unsporulated. How about for letter B? This life stage contains sporozoites. No, wala pa ni mature ang sporoblast ani sa feces in terms of Isospora belli. This life stage has already sporulated again. Mo sporulate pa siya sa outside environment. This life stage has undergone gametogony. That is correct because gametogony leads to the formation of the oocyst. Okay, next we have Cyclospora cayetanensis. So Cyclospora cayetanensis is most recently described human intestinal coccidian, and this is the causative agent of seasonal outbreaks of prolonged diarrhea, especially in rainy na mga months. It is prevalent in South Asia, and humans are the only known host for this intestinal coccidian, much the same as your Isospora belli. For its sporulated oocyst, it is round 8 to 10 micrometers and it contains 2 sporocysts, kani sila here, with 2 sporozoites each. So it's unique because C. parvum na siya 4 sporozoite, walay sporocyst. Si Isospora belli na siya 2 sporocysts which contains 4 sporozoites each. Pero si Cyclosporia cayetanensis na siya 2 sporocysts with 2 sporozoites each. By the way, ang oocyst sa imuhang Cyclosporia cayetanensis kay unsporulated in feces, meaning that it also sporulates in the outside environment, much the same as T. gondii and Isospora belli. Okay, let's have this checkpoint number 11, modified true or false, and the premise is C. cayetanensis has distinct morphologic characteristics in its life cycle. Statement number 1, the oocyst of Cyclospora cayetanensis is immediately infective when excreted by the host. Statement number 2, the sporozoites within the oocyst of Cyclospora cayetanensis become infective after sporulation in the environment. What will be our correct answer for this one? The correct answer is letter B. Why B? So let's have statement number 1. The oocyst of Cyclospora cayetanensis is immediately infective when excreted by the host. Again, when you say C. cayetanensis, the oocyst is unsporulated in feces, meaning that it needs sporulation in the soil or outside environment. So obviously, the statement 1 is false. How about statement number 2? The sporozoites within the oocyst of Cyclospora cayetanensis become infective after sporulation. That is correct, no? So meaning statement 2 is true, statement 1 is false. As for the mode of transmission, its life cycle is actually the same with C. parvum, except for two things. It is unsporulated in feces and it requires sporulation in the soil. So this is what occurs in the asexual phase of C. parvum, much the same as this is what occurs in the life cycle of C. cayetanensis, much the same as C. parvum. It starts with ingestion of sporulated oocysts, then proceed with invasion and schizogony. For the sexual phase, it starts with gametogony, then oocyst formation, then sporulation in the outside environment. Okay, then we have checkpoint number 12. What is the primary route of transmission for Cyclospora cayetanensis? Is it A. Inhalation of oocysts, B. Ingestion of contaminated food or water, C. Direct contact with infected animals, or letter D. Mosquito bites? What will be our answer for this one? Of course, that would be ingestion of contaminated food or water that is contaminated with sporulated oocysts. So, ingana lang na for Cyclospora cayetanensis. For its disease condition, it's self-limiting diarrhea that resembles C. parvum for immunocompetent hosts. It's more severe in immunocompromised hosts, especially with biliary tract involvement. So this can lead to prolonged diarrhea, abdominal pain, low-grade fever, and fatigue. What really happens in the villi, is that it will lead to the blunting and the atrophy that the villi experience and hyperplasia of the crypts, meaning there's a change in the, how do you call that, a feature of normal cells in the lining epithelium, which also disrupts the absorption of nutrients as well as the water, which leads into hypermotility of the GI tract that causes or that eventually lead to diarrhea. So, ingan ang nahitabo sa epithelium or sa intestinal tissue na gina-infect sa mga coccidia. The incubation period for for cyclosporiasis or Cyclosporia cayetanensis is about 1 to 7 days. For its laboratory diagnosis, still the same with other intestinal coccidian. For its acid-fast, they are variably acid-fast. Means like variably, some of them are red, some of them are blue or colorless, meaning dili gyud reliable ang iyahang pagka acid-fast. Kaya uban mo acid fast positive, na po uban nga acid fast negative. Although the oocysts of Cyclospora cayetanensis are strongly autofluorescent in UV microscopy. So that's how we can differentiate the three oocysts of these intestinal coccidians. We can also perform, aside from stool examination, molecular diagnosis in the form of RT-PCR. We can also add flow cytometry to this. In serology, we can detect for antibody, and for histopathology, we can detect for the positioning or where can we locate the intestinal locations, not intestinal but intracellular locations of C. cayetanensis as compared with C. parvum. Di ba remember C. parvum, it is in the intracellular extracytoplasmic region. And for C. cayetanensis, this can be found supranuclear from the nucleus of the intestinal epithelial cells. So that's how we can differentiate them based on histopathology of intestinal biopsies. Next, for the treatment, we can administer, or the doctor may administer cotrimoxazole. And of course, for HIV or AIDS patients, long-term suppressive maintenance therapy should be utilized. Next, we have checkpoint number 13, which is a case scenario. A 45-year-old man presents to the clinic with complaints of intermittent watery diarrhea, cramping, and bloating for the past 2 weeks. And he mentions that he recently traveled to a rural area where he consumed raw fruits and vegetables, as well as unfiltered water. Stool samples are collected, and laboratory results confirm an infection with Cyclospora cayetanensis. Which of the following statements about the pathogenesis of C. cayetanensis is true? Is it letter A, C. cayetanensis causes direct invasion of the bloodstream, leading to systemic symptoms? Or letter B, the infection is characterized by acute diarrhea with a quick resolution, typically within a few days? Letter C, the oocyst must sporulate in the environment before being infective. Or letter D, Cyclospora cayetanensis primarily infects the large intestine, causing damage to the epithelial cells. What will be our best answer for this one? The correct answer is letter C. So, in letter A class, dili siya maka-cause of direct invasion of the bloodstream because in fact, it is an intestinal coccidian. So, usually, much of the disease that it causes is in the epithelial cells of the small intestine. How about for letter B? The infection is characterized by acute diarrhea with a quick resolution, typically within a few days. That is partly untrue because in immunocompromised individuals, it causes chronic diarrhea. For letter D, Cyclospora cayetanensis primarily infects the large intestine. That is also untrue. It's the small intestine that is primarily infected by the parasite. So the best answer is letter C. The oocyst must sporulate in the environment before being infective because unsporulated oocysts are released in the feces. Okay, so here is a table of differentiation which you can read, and please memorize this one for easy studying. This is actually a life hack that is provided by Essentials, and this is a good table for differentiating the three intestinal coccidians. Finally, we'll be discussing the last opportunistic coccidian, and that is Sarcocystis species. Sarcocystis species is a zoonotic parasite, meaning that it infects animals and we can get the infection from the animals. In fact, class, the Sarcocystis species infect a wide variety of animals, including birds, reptiles, and mammals. Human infection is quite low, and it's the lowest as compared to other coccidia. It was first described in house mouse skeletal muscle in Switzerland in 1843. And man can be an intermediate host and can also be a definitive host depending on the species of Sarcocystis. In intestinal sarcocystosis, also known as sarcosporidiosis, man acts as the definitive host, particularly in species of S. hominis and S. soy hominis. So the intermediate hosts for S. hominis are cattle, whereas for S. soy hominis, the intermediate hosts are pigs. Usually, in terms of pathogenicity, intestinal sarcocystosis can be severe and life-threatening at occasions. For muscular sarcocystosis, man acts as the intermediate host. The definitive host is not truly identified, but it is believed to be cats or dogs. So, the causative agent for muscular sarcocystosis is a group of unidentified sarcocystis species referred to as S. lendi-manni. What's unique about the muscular sarcocystosis is that the morphologic form associated sarcosis may last long for about 5 years. In terms of their morphologic forms, here we have its three morphologic forms. The sexual form is the oocyst and even the sporocyst, whereas the asexual form is the sarcocyst. The oocyst is found in the intestine of the definitive host. It is already sporulated in the lamina propria, meaning that it is already sporulated in feces. The oocyst is elongated and thin-walled. It's about 13 to 19 micrometers in soy hominis and relatively smaller 10 to 13 micrometers in S. soy hominis. And this sporulated oocyst contains two elongated sporocysts with four elongated sporozoites, much the same as the Toxoplasma gondii and Isospora belli. The sporocysts are released in feces as oocyst dissolves. So because the oocyst is thin-walled, some of the oocyst actually is dissolved and they will release the sporocysts. And the sporocysts are oval, about 9 to 16 micrometers, which are infective to the intermediate host as they contain viable sporozoites. The last morphological form is the sarcocyst, and mao ni sila ang mga cysts that can be found in the muscles, in cardiac and skeletal muscles of the intermediate host, particularly sa diaphragm and esophagus. They're elongated with a range of size from 100 to 325 micrometers. They're thick-walled and is surrounded by parasitophorous vacuole. They're usually, as you can see here, situated longitudinally along the muscle fiber. The sarcocysts also possess many compartments that contain the banana-shaped bradyzoids or metrozoites. And as you know that the bradyzoids are strongly PAS positive because of their amylopectin granules. Now we have here checkpoint number 14. Which of the following statements about the morphology of Sarcocystis species is correct? Is it letter A, the sarcocyst is typically round, measuring 10 to 100 micrometers and contains numerous bradyzoids arranged in a cystic structure? Or letter B, Sarcocystis oocysts are large and contain sporozoites that are capable of infecting humans directly after excretion? Or letter C, the trophozoites of Sarcocystis species are found in the muscle fibers of the definitive host and are not visible under light microscopy? Or is it letter D, the oocyst wall is thick and is composed of a dense multi-layered structure that is easily distinguished from surrounding tissues? Which of these choices is the best to describe the morphology of Sarcocystis species? The correct answer should be letter A. So letter B is wrong, class, because the oocyst needs to be eaten first and released from the the how do you call that, the sporozoites of Sarcocystis needs to be eaten first to be released from the sporocysts because before they can be infective. They can be said to be infective to the host. Dili kay directly after excretion kay maka-infect na dayon sila. No. Kailangan pa nilang kaunon, kailangan pa nila to liberate from the sporosis. How about for letter C? The trophozoites of Sarcocystis species are found in the muscle fibers of the definitive host are not visible under light microscopy. Bradyzoids can actually be seen under light microscopy in that they do not form in the definitive host. Usually in definitive host, kay katong mga sexual forms of the parasite. For letter D, the oocyst wall is thick and is composed of a dense, multi-layered structure that is easily distinguished from surrounding tissues. That is wrong because the oocyst of Sarcocystis species is thin-walled. Mabiton na nga usahay, mawala siya ma-dissolve. Ang naana lang is the sporocyst. So here's the mode of transmission. The life cycle of Sarcocystis species follows in an obligatory two hosts na tay predator and prey, two hosts siya. So that's heterocinous. Ang predator, which is usually carnivorous, follows the sexual life cycle, whereas the prey, which is usually herbivorous, follows the asexual life cycle. The mode of transmission in terms of Sarcocystis hominis is the ingestion of contaminated beef. For Sarcocystis soy hominis, that's ingestion of contaminated pork, whereas for S. lindemani, that is ingestion of contaminated food and water. So for the sexual cycle that occurs in the definitive host, it starts with the ingestion of the sarcocyst, followed by invasion, gametogony, oocyst, and sporocyst formation. So in the ingestion of the sarcocyst, this can be from contaminated pork for soy hominis or beef for hominis, and this will lead to the release of the bradyzoites or merozoites that penetrate the intestinal mucosa. So once the bradyzoites are released, this will invade the intestinal epithelium, and this will transform to microgamete and macrogamete. The microgamete and macrogamete will undergo gametogony, and eventually the microgamete fertilizes the macrogamete, leading to the formation of the zygote that secretes the cyst wall. After that one, oocyst matures and becomes sporulated, containing 2 sporocysts, each with 4 sporozoites. And because these oocysts are thin-walled, sometimes the sporocysts are released from the oocysts as they get dissolved. It means that both sporocysts and sporulated oocysts become the diagnostic stages of Sarcocystis species in the feces. For the asexual cycle, it will start with the ingestion of the sporocyst containing the viable sporozoites, then it will lead to schizogony, then lastly to sarcocyst formation. So in the ingestion of the sporocyst, this will liberate the 4 sporozoites from each of the sporocysts, and this will directly invade the intestinal blood vessels. Mga to siya sa blood vessels dayon. So in the blood vessels, there are 2 generations of schizons that will be formed within the vascular epithelium. And then this can be about 15 to 16 days after ingestion of the sporocyst. The parasites will multiply in the direction of the blood flow. And finally, third asexual generation occurs within the capillaries throughout the body until such time that the parasite will reach the target muscular organs. So after third generation, the schizons there will rupture to release merozoites that will invade the skeletal and cardiac muscles. There, it will transform into sarcocysts with metrozoites. By the way, metrozoites are still not infective, so it will differentiate into bradyzoites that are already infective. So that's the end point in the life cycle of the Sarcocystis species. For its clinical features, usually asymptomatic, take note that here man is the definitive host. So, man may develop nausea, vomiting, abdominal pain, and diarrhea. You cannot really differentiate the types of Sarcoidosis species in terms of their clinical features, but usually symptoms for S. hominis occurs 3 to 6 hours, whereas for S. soy hominis, it occurs about 24 hours after the initial exposure. For muscular sarcocystosis, it is usually asymptomatic, and the symptoms depend on the size of the cyst, which may range from 50 to 5 centimeters. This involves muscle pain, weakness in the muscle, and at rare points, focal myositis and eosinophilic myositis. When we say focal myositis, that's the appearance of a large benign pseudotumor due to the growth of the sarcocyst. And when we say eosinophilic myositis, that is aside from the fact that there's myositis, there's also high eosinophil count. Myocarditis and pericarditis may also occur if the sarcocysts develop in the cardiac muscles. But it's often in the skeletal muscles that the sarcocysts will develop more than the cardiac muscles. For laboratory diagnosis for intestinal sarcocystosis, of course, it's the stool exam. In the stool exam, you cannot differentiate if the causative agent is hominis or soy hominis. However, S. hominis sporosis occurs 14 to 18 days after the initial exposure, whereas S. soy hominis sporosis occurs 11 to 13 days after the initial exposure. Concentration techniques can be performed in the form of flotation technique, that is to concentrate samples to maximize yield of oocysts or sporocysts. The sporocysts of sarcocysts are also autofluorescent in UV microscopy. So we have to take note of that also. For muscular sarcocystosis, that can be diagnosed through histological examination through muscle biopsy to demonstrate the sarcocyst. Remember that the sarcocyst contains the bradyzoids that are PAS or periodic acid SCIF positive, which serves as the confirmatory staining for the presence of sarcocysts. In acute infection class, the sarcocysts are still immature and there's inflammation going on in the infected area. In past infection, the sarcocysts are already mature without inflammation around the surrounding area. Serology can also be performed in the form of Western blot that detects the antibodies, although this is not diagnostic of acute diseases. Other tests that we can perform includes elevated erythrocyte sedimentation rate, which will indicate that inflammation has been occurring, and elevated creatine kinase, which will indicate that there might be muscle damage due to the formation of sarcocysts within the muscles of the intermediate host. For the treatment, no specific treatment is intended for sarcocystosis species. Cotrimoxazole, furazolidone, and albendazole are used, but the efficacy is doubtful. Corticosteroids may provide symptomatic relief in cases of intense pain for patients experiencing eosinophilic myositis. Finally, let's answer the last checkpoint number 15. Which of the following statements about the life cycle of Sarcocystis species is true? Is it letter A, sexual reproduction occurs in the intermediate host, where oocysts are produced and excreted? Letter B, sporozoites are released from oocysts in the definitive host, where they directly infect the intermediate host. Letter C, the intermediate host forms sporocysts in muscle tissues, and the definitive host consumes these to complete the life cycle. Or letter D, the definitive host harbors the sexual stage and the intermediate host forms sarcocysts where asexual reproduction occurs. What will be your answer? The correct answer is letter D. The definitive host harbors the sexual stage, and the intermediate host forms sarcosis, where asexual reproduction occurs. In letter A, it is wrong because sexual reproduction occurs in the definitive host. How about for letter B? Here, sporozoites are released in the GI tract of intermediate host, not in definitive host. Letter C, the intermediate host forms sporocysts in the muscle tissues, and the definitive host consumes these to complete the life cycle. To, sorry, to complete the life cycle, it's not the sporocyst. It's what makes the statement in letter C wrong is that it's not the sporocyst that develops in the muscle, it's the sarcocyst. So we have to take note of that. So therefore, the best answer for this one is definitely letter D. The definitive host harbors the sexual stage, and the intermediate host form sarcosis, where asexual reproduction occurs. And that is the end of my lecture discussion. Thank you very much, everyone, for listening. I hope that you really study for the quiz and the upcoming long examination number 2, as well as the upcoming periodical examinations. If you have any questions, please do not hesitate to ask me. I will be willing to answer your questions to the best of my ability.